All right, today we are going to cover respiratory. Before we jump into that, I do need to clarify something that I said last week on our cardiac lecture. I got my numbers backwards. So when we were talking about the cardiac catheterization, that cover site, where that insertion site where we put in that, we inserted that catheter, we changed the bandage every day for 2 to 3 days. I had the numbers backwards. So change that bandage every day for 2 to 3 days, keep the site clean and dry, observe for signs of infection, encourage rest and quiet activities, avoid strenuous activities, resume regular diet without restrictions, just Tylenol for pain. Got all of that right. I just said my numbers backwards. So change the bandage every single day. Typically it's 2 to 3 days. Okay. Any questions about that? So sorry, I got that backwards. Any questions? No? Okay. So I just want to make sure that I got that before we got started. Okay, so now let's talk about our respiratory lecture. So I was looking at our content. My goal is to get all of the content covered this week, so we have Monday before our exam to review. So we're gonna not go fast, but we're gonna get things covered. So hopefully that works out for us. Okay. All right, so let's talk about some of the reasons that we see so many more respiratory infections in our pediatric population as compared with our adults. So there's several key differences starting from just our structure. Okay, that sounds good, Stacey. Can everyone else hear me? I did unmute myself. Everyone else can hear me?
Yes.
Okay, great. All right, so Stacey, you log back in. Hopefully that will help you. All right, so looking at our anatomical differences, firstly, just based on size, our pediatric population is going to have more narrowed nasal passages. This allows things to get stuck in there. So if we've got bacteria or some type of pathogen that's growing, or we just have that blockage from mucus, it's going to have the capability of increasing the potential for sitting in there and then potentially causing infection, okay? There's fewer functional airway muscles. Because our pediatric population hasn't had an opportunity to expand those lungs and utilize those lungs as much as the older child or the adolescent adult would have, they don't have that same capability of breathing harder to move past that respiratory situation. We've got more surface tissue based on our body size, and an increased mucus gland ratio, which means that we have a greater propensity or capability of trapping those pathogens, letting them breed and turn into an infection, okay? Immature thyroid, cricoid, and tracheal cartilages, meaning that if we have something going on in here, we've got some type of epiglottitis or inflammation in this area, we don't really have a way of working past that. Last week, we talked a lot about how our pediatric population does not have the same compensatory mechanisms when it comes to trying to work through poor circulatory output or something like that. It's the same thing when we have it in the respiratory standpoint, okay? Those intercostal and accessory muscles are poorly developed, goes right into that same compensatory mechanism. They don't have the same capability of just getting to Kipnik and breathing off that extra CO2 or using some of those accessory muscles to breathe deeper while other parts of their lungs are structured or are having issues, okay? And that large abdomen, that's especially important for our infant and newborn because we can trap air in our belly. Right. And for adults or older children, it's not that big of a deal because the belly's big enough to be able to take that. The air is just going to move through the rest of the digestive system. But for our baby and our infant who have, very small compartments, filling that abdomen with air means it's going to put pressure on our diaphragm. As we put pressure on the diaphragm, it means that our lungs are not going to be able to expand as well. Okay. So because we have all of that pressure stacked in, we already have a respiratory problem. The deeper or the more that baby breathes, the more likely we are to get that air to go down into the belly, which means it's going to make our situation even more difficult. Okay. Looking at some of the influences on infection, most of this is going to be a repeat. When we look at age, we know that those who are really young or really old are always at a greater risk of succumbing to an infection. They have a decreased immune response. For a pediatric population, they really just haven't been around enough infections or enough pathogens to really have their body be able to mount their own response. Okay, we see that especially in that first year. The smaller airway size we already talked about. We've got that increased risk of obstruction. If we've got edema or if we've got mucus that's filling our airways, it's harder for us to breathe past that. Those shorter airways also mean that pathogens can move much more quickly than they can in the older child or adolescent. Meaning that they're going to go from insertion point or point of entry, either in our mouth and our nose, to our lungs much more quickly and have that opportunity to cause sickness earlier or faster. Okay. Decreased resistance. So this increases our risk of infection. Other factors that we haven't covered yet, premature birth. Anytime we're born early, all of our systems are going to be less developed, which means our ability to fight infection, so our immune system, our ability to try to work through that situation with our compensatory mechanisms are not going to be as efficient. Bronchopulmonary dysplasia is typically a respiratory infection that's a respiratory condition, not an infection, secondary to being born premature, because the baby had to work through that less developed respiratory function. Sometimes it can cause that complication. Okay. Asthma is going to increase the likelihood of succumbing to an infection. We already have inflamed pathways, so it makes it that much easier for it to affect us. History of RSV, which we'll cover in just a little bit, those cardiac anomalies like we talked about last week, cystic fibrosis, which we'll cover in a little bit, and vaccine status. We get a lot of vaccines within that first year, but we may not be protecting that infant from what he's being exposed to. And there are some things that we just don't have vaccines for. Okay. When we talk about seasonal variations, we're talking about how cold, flu, RSV, typically we see that in the winter. We also see a RSV in the spring. Seasonal allergies can play a part here. Sometimes something starts as seasonal, cedar fever here in Austin. And because we have those inflamed pathways, the child gets exposed to an infection and he's unable to fight that as efficiently. Okay. Okay, so looking at some of our generalized clinical manifestations of respiratory dysfunction, first we have respiratory distress. The smaller the baby, the more dramatic this is going to appear because those airways are so small. Okay, so grunting is something that we hear on expiration. It's a way of trying to open up those higher airways up here. Nasal flaring we see right here, same thing. We're trying to take in more oxygen. Retractions we're going to see in those intercostal and supracostal, subcostal spaces. It's really just the visualization of those accessory muscles trying to fix the situation. Tachypnea we know is a compensatory mechanism. We're trying to take in more oxygen, breathe off more CO2 to balance our acid base. Okay. Fever we may see depending on which infection we're talking about. We don't always see that. We typically don't see that in our newborn period because the capabilities of thermoregulation are so immature. Even in our term infant, we're more likely to see a low temperature within that first month of our baby being born. And that is really more telling than a high temperature would be. Okay. Anorexia is very common. Really, this just means that the child has no interest in eating. Okay. A lot of this comes from pain that he may or may not be able to verbalize in this area, or it's just he doesn't feel well. He doesn't feel like eating. Okay. In our infant, this is going to be a high risk for dehydration, which we'll cover either tomorrow or Monday in that GU section. So we have to be very mindful about fluids, okay? Vomiting, we may see, especially in our young population, if we've got excess mucus, they have to get rid of it some way, and typically that's going to happen through vomiting, okay? Nasal blockage, discharge, we may hear some stuffiness, especially when they're feeding. It's going to make feeding more difficult, either breastfeed or bottle feed, the younger that baby is, okay? All right, so what would you do about that? Essentially, we provide supportive care. Supportive care means we provide for whatever needs the patient has. All right, so we're going to ease respiratory efforts. This may be a position change. It may be that we actually put on oxygen. Really depends on how severe the situation is. Okay, promote rest and promote comfort. If our baby is, he's having difficulty with mucus, we can try to alleviate some of that suction, some of that out. We do want to be mindful and to tell our parents, the more we suction, the more likely we are to inflame those airways. So try to just do it as necessary to allow that baby to breathe comfortably. Prevent spread of infection. Think about your hand hygiene. Think about it not only in that baby going from one area to another, but think about other children or other people in that house. If the child goes to daycare, we need to keep him home. And try to prevent that from being spread to other children outside the home. Okay, reduced temperature really depends on the school practice that your pediatrician really follows. The evidence shows that as long as the child is not showing that he is uncomfortable, we want to let the infection we want to let the body try to fight the infection without bringing down that fever. Okay, the body brings up the temperature trying to kill that pathogen. That's the natural process. And as long as the child is able to deal with that elevated temperature, 102, etc., we want to let his body do that. If the child is unable to rest, is crying or protesting, then we can give that medicine, or if that temperature starts to creep up about 104. So depending on what your pediatrician says, depending on what pathogen we're talking about, it may be better to give that acetaminophen, that Tylenol. Okay, promote hydration, nutrition. If a mom is breastfeeding and the child is sick, especially in that first year, typically the child wants to nurse more frequently. Some of this is going to come out of that child's need to be comforted. The other is going to be that body understanding that they're not taking in enough fluids. So it tends to be more frequent nursing with less time, especially if that baby is having issues with holding onto his mucus in his belly. Okay, so instead of his typical, 15 to 20 minutes every 3 to 4 hours, it may be more like 5 to 10 minutes every 2 hours. Not ideal for parenting, but just reinforce that this is going to be short-lived. Okay, and then we provide family support. So education is a big point here, ensuring that the parents or the caregivers understand all of the things to watch for. Is this getting worse or is this getting better? Right. All right, now we're going to start talking about some of our specific infections that you guys need to be familiar with. The first thing that we're going to cover is upper respiratory tract infections. All right. You do need to be familiar as we're going through this. The young child, including the infant, may present differently than the older child. So like we talked about last week, look for those differences. Okay. That's really going to help you when you get into your exam, looking at the different things. There's going to be some overlap in symptoms, but look for those things that are just specific to the young child or just specific to the older child. Okay. So with nasopharyngitis, we have, can you let me into the room? I'm sorry, it didn't give me, I don't have anybody in the waiting room. I'll be happy to let you in, but it's not telling me that anybody's in the waiting room. All right, so we've got some numerous viruses here in our young child. We have fever, irritability, poor feeding, vomiting, and diarrhea. Tend to have copious nasal secretions that we'll have to suction. In the older child, we're going to have the dry, irritated nose and throat, Nasal discharge may cause mouth breathing, sneezes, chills, cough, muscle aches, edema, and vasodilation of the mucosa. The older child is more likely to be able to share the symptoms, and the younger child, we just have to rely on what we can see. Okay. Cheryl, I'm still not seeing you in the waiting room. Are you sure you're in the right room? I mean, obviously you're in this room, but however else you're trying to get in, I'm not seeing you. All right, so as we covered, the clinical manifestations vary with age. The therapeutic, because this is a virus, there's no cure. We really just provide that supportive care and try to work through the situations, okay? So we encourage fluids. If we're breastfeeding or bottle feeding within that first year, we do that more frequently, typically smaller volume. We want to encourage rest. Most of the time, this is going to be no problem, especially in those first couple of days, because that's all that child is going to want to do, all right? We may have to elevate the head of bed. We do have to be careful, especially within that first year. You know, we need to do back to sleep. We need to do nothing, no pillows or anything. A lot of times when we have a sick infant, it means that that mom or that caregiver, that parent is sitting upright with that child. Not ideal, especially when it comes to nighttime and that parent wants to sleep. We want to reiterate how unsafe it is falling asleep with your child. It's a very difficult time. If that parent has someone else that they can rely on, switching off between other caregivers, that's ideal. But we want to encourage that parent to not fall asleep, especially in that chair with that child, because that child could fall and hurt himself. Okay. Suction, we talked about. There is, you know, when I was pregnant, I was looking at all the things that I might need in that first couple of months. There's something called a nose Frida. It's really disgusting because you actually use your mouth as a suction. There is a filter, excuse me, there's a filter that's supposed to protect you. And in my experience, every time I used it, I never got my son's mucus into my mouth, but the whole thought process is a little disgusting. But you put the little aperture in your mouth, you put the plunger area in the child's nose or mouth, whatever you're suctioning, and you suck, and that pulls out that mucus. The child is going to protest, and it's really quite funny because as a NICU nurse, I have suctioned thousands of children. Really, I mean, I didn't want to cause the children any pain, but it didn't really, you know, hurt my heart to do that. The first time I had to do it on my child, you know, he's crying, I'm crying. It's very traumatic for both of us. But, you know, we want to do it as frequently as we need to, because moving that air or moving that mucus from the airways, one, is going to help that child breathe easily or more easily, but it's also going to prevent or decrease the propensity for any of those pathogens that are in that area to continue to breathe. Okay. Prevention is key. Hand washing, cough etiquette, teaching your child as soon as he's really unable to understand commands, teaching him to cough into his elbow or at least use his hand, and then do some hand sanitizer after that, trying to prevent that spread of infection. Okay. Pharyngitis. So now we're a little bit lower. We're just in this area here out of the nose. 80 to 90% cases are going to be viral, which means that we're just providing supportive care. There's not typically any medication that we're going to provide. Strep throat is the most common culprit here. Okay. Clinical manifestations, again, are a little bit different in our young and our older child population. So in the younger child, we see that fever, that general malaise, I just don't feel well. Anorexia, may have a moderate sore throat. Young child typically is not going to be able to verbalize that. Headache may also be associated. We may not be able to get that information either. Mild to moderate hyperemia. So we see that redness area of our tonsils and pharynx. That's due to that increased blood flow, right? The body pushes more blood to that area because in our blood, we have our white blood cells. That's how we're going to try to mount that infection. Also, that inflammation gives us increased blood flow in that area. So that's what causes that red color. All right. In our older child, the fever can get up to 104. Again, we only want to treat the fever if it's causing the child discomfort. Otherwise, we want to let the body do its thing. Child is likely to complain of that headache, that dysphagia, that difficulty or pain swallowing. Anorexia, abdominal pain may also be associated in the older child. May see that vomiting. Again, we're going to have that hyperemia in that red or that redness of the tonsils and pharynx. It's also going to look inflamed or edematous. We're going to have abundant exudate, meaning lots of mucus coming out the nose. May get to the point where the child who isn't typically a drooler may be drooling, just trying to get rid of that mucus. And in the older child, we may also feel those enlarged cervical lymph nodes. They're not very easy to fill in our small child. They may very well be inflamed. They're just not as easy to palpate. Okay. So looking at our infection or our diagnostics, if it's strep throat, there's a great test that we can do for that. We've got our rapid strep antigen that's going to be able to tell us, yes, this is strep, or no, it's not. If it's viral, typically there's no medications. If it is strep, we're going to give that penicillin. Okay. Or if there is a penicillin allergy, we may give something different. All right. We do want to be mindful. This no school or daycare for 24 hours with no fever and after antibiotics is a really important point to understand. You may see that again. So no school or daycare for 24 hours with no fever and after antibiotics if we're dealing with strep throat. Okay. Typically, the child is not going to even feel better at that point. So he may stay home for a couple, at least one more day until he's feeling a little bit better. You can give acetaminophen or ibuprofen depending on how old our child is for that throat pain if he's really protesting. And then as far as your parent education, your caregiver education, make sure that they take the full course of antibiotics to make sure that we completely kill off that pathogen if they've been prescribed. Okay. All right, with tonsillitis, now we're going further down our airway here. This often occurs with pharyngitis just because they're in such close proximity. Again, our agent could be viral or bacterial, so that's going to depend, or that's going to determine, are we going to do antibiotics or not? If it's not bacterial, no antibiotics. Clinical manifestations are not too different in our pediatric or our young and our older child. So we see that enlargement of our tonsils may get to the point where there's difficulty swallowing. We're going to see that mouth breathing because all of the nasal area is inflamed. All right. Remember, with grading of our tonsils, 1+ is what we have as normal. Okay. There's no inflammation. 2+, they're slightly enlarged. 3+, when that child opens their mouth, the tonsils are halfway to the uvula. And at 4+, those tonsils are touching each other. 4+, we're going to have a lot of protesting from that child. He's going to be in a lot of pain, and the mouth breathing is going to be more present. It's going to be really hard for him to breathe past that. Okay. So antibiotics, if bacterial, we may have to do a tonsillectomy. We'll talk more about this procedure in just a second. If there's certain criteria, they don't do, it's not just one case of tonsillitis and let's take out your tonsils. This is for the child who has frequent infections to the point where it's getting disruptive. Okay. So it's not something that they decide on lightly. It's a procedure that is occurs with frequent strep throat infections, or if there's some type of airway obstruction. Okay. Typically, when they take out the tonsils, they also take out the adenoids because they kind of work together as far as that obstruction or as far as that infection causing situation. And we call that procedure a T&A. Okay. So tonsillectomy and adenectomy. It's typically a pretty easy surgery. The biggest complication is going to be post-op hemorrhage. All right. What you're going to see in this child if he is starting to hemorrhage, is frequent swallowing. All right. The complaints of pain, that's very common. He had pain before from that infection, and then we did cut out those tonsils and or those adenoids. So there's going to be some pain there. Pain doesn't really give you that big factor. It's that frequent swallowing, because that child is trying to remove that blood from his airway, that's going to be your big red flag. Okay. Things that you need to do in post-op care, we want to give cool, clear liquids, definitely no red liquids, as we could confuse that with blood. No milk or milk products, as that can be inflammatory to that area. Frequent swallowing, like we covered, indicates that there's bleeding. This is an emergency situation, something that we want to report right away so we can get on top of it. If that patient starts vomiting bright red blood, this is another big issue here. We want to report that. We want to call the surgeon and make sure that we're dealing with that. We want to keep that child as calm as possible. Okay, we don't want him to bust those sutures that are in place where those tonsils were removed. So we avoid or try to prevent that child from coughing, from sneezing, from crying, from screaming. So we keep him very calm, which is why we need to give those pain medications around the clock. All right. That is going to helpfully keep that child comfortable until he's past the painful period. We're able to heal, not bust those sutures, not have any potential hemorrhaging. All right. All right, you guys have any infection or any questions about our upper respiratory infections?
So no ice cream, right?
No ice cream, no. We could do popsicles though, as long as they're not red.
Okay.
All right, so now we'll talk about otitis media. And the reason otitis media comes up in our respiratory lecture is because frequently when we have children who have mucus in this area, because the way the physiology is at that point, our eustachian tubes are more parallel to our nasal mucus or our nasal airways. So if we've got infection breeding in here, it's very easy for it to get into that parallel eustachian tube. In the older child and the adult, our eustachian tubes go down like this. We have a nice drainage pathway built in. It goes down into the back of our throat. We swallow it, we move on. It's not that big of a deal. This is why ear infections in adults are pretty unheard of, pretty rare, because of that positioning. All right. So we've got mucus and pathogens in here, very easy for it to get into that parallel eustachian tube. All right, so lower the age or the younger the age, the increased risk we have for ear infections. Breastfed babies, this is an interesting point to note. Breastfed babies do have a decreased likelihood of getting ear infections. Does anybody know why? Why do we see that less than breastfed babies?
Is it because like they're not, I don't know, like the air in the bottle or something with the bottle?
That's one factor. So the position is a little bit different. We typically hold our baby when we're breastfeeding more upright than we might if we were bottle feeding. So position has a big factor. The biggest thing is because breastfed babies get more immunoglobulin A from mom, and that increases that baby's capability of fighting infections. So it's not that he's not exposed to them, he just has that increased antibody response from that breast milk that the strictly bottle fed baby, formula bottle fed baby would not get. Okay. We often see ear infections after upper respiratory infections because of that stagnant mucus. Okay. So different things that we need to look at. So we've got otitis media. So that is the internal ear. All right. So we've got presence. You can see our normal ear tympanic membrane over here. This one is bulging. You know, the eardrum is supposed to be concave. You can see that this one is completely pushed out. It's red. It looks real angry. The child is also going to protest, right? Typically, these babies are very angry, very fussy. They're hard to settle. They don't want to lay down and eat because that puts more pressure on the ear. The older child, the older infant may pull on their ear because it's causing them pain. So maybe something that we see there, okay? That OME, now we've got presence, that's in our middle ear. We've got presence of fluid. that fluid in the middle ear, sometimes we can see that with our, just from what we're seeing on the outside. Typically, we're going to need an otoscope to see that. Okay. So this is something that the doctor would be able to see. May or may not have symptoms of infection. You know, every child has a different temperament. Some protest more loudly when this is going on. So you may know early as a caregiver or parent that this is going on, and it may not be until it's more severe based on how that child is presenting to you. If you had a child who had a upper respiratory infection, he had just gotten over some type of mucousy situation and started showing some signs of pushing on his ear or just being angry after the fact of having that upper respiratory infection, it would be a good idea to get him checked out to see if that had turned into an ear infection. Okay. If it's antibiotic, same thing, or sorry, if it's bacterial, we're going to give some antibiotic ointment or ear drops. It becomes increasingly less common the older that child gets. Okay. So as that child gets older than 7, typically very rare that this would happen, that they would have an ear infection. But it does tend to follow upper respiratory infection. We see that connection with the ear just because of that mucus that can be in that area all in here. Okay. All right. So if it's bacterial, we're going to treat that. So acute ear pain, tend to have a fever with this as well. Again, the child may or may not pull on that ear. In the first year, my child would sometimes just tug on his ear and I'd be like, oh my goodness, do you have an ear infection? And then he would just go back to playing. So it doesn't always, it's not just the pull on the ear and automatically you have an ear infection, but it can be something that we see. All right. With chronic otitis media, we may start to see some signs of hearing loss, which is why we want to be on top of it. The more damage we do to that tympanic membrane, the more likely we are to have hearing loss as a consequence. Okay. So if we have children, just like we have children with frequent strep throat infections or frequent tonsillitis, we may do that surgical procedure. For otitis media, if we have children who have frequent infections, we may put in something called tympanostomy tubes or T-tubes into their ears that help facilitate that drainage just a little bit better. It's an easy surgical procedure, but again, we don't want to do it unless it's a frequent problem, with the idea of we want to prevent any hearing loss for our babies with frequent infection if possible. All right. With the older child, they may actually report tinnitus, so ringing in the ears, or vertigo, which means the room is spinning. Could again happen with our young child. They're just not going to be able to report that. Okay. So antibiotics, if we're bacterial, possible tympanostomy tube. Nursing management, it goes back to that supportive care. All right. We relieve pain. We try to prevent recurrence. There's some education points that we want to provide for the family. If they're using a bottle, we want to make sure that they're not propping. The more parallel or the less elevated that child is when they're eating, whether it's breastfeeding or bottle feeding, the more likely that milk is to get into that eustachian tube kind of through a backflow and just sit there. And just like stagnant water, stagnant milk, whether it's formula or breast milk, is going to increase the likelihood of developing an infection. So we want to make sure that they're not doing that they have that baby upright, elevated, whether it's breast or bottle. Avoid passive smoke. Passive smoke means that this is the smoke that's on your clothes. We don't have smoke that I'm not directly smoking into my child's face, but the passive smoke is on the skin or on the clothes. And that can increase the inflammation of the airways, increasing the likelihood of pathogens getting stuck into those inflamed airways. All right. And then immunizations, just like we can prevent some of our upper respiratory infections by staying up to date with our immunizations. If we're preventing those upper respiratory infections, we can also prevent those potential ear infections secondary to those respiratory infections as well. Okay. All right, so the next thing we're going to talk about is croup syndromes. We often talk about croup as just one collective thing, but there are 3 different types of croup that we can look at. So we've got epiglottitis, laryngitis, and I'm just going to call that last one LTB. That's a really hard word for me to say. So you can see it affects all of those areas, the larynx, the trachea, and the bronchioles, okay? When we're talking about croup, there's a very distinctive cough. We call it the barking cough. If you've never heard this, I don't have any examples in the lecture, but if you've never heard this, you can go to YouTube and type in croup cough, and you'll get a great earpiece for it. But it does sound like the child is barking, okay? So it's very distinctive as far as listening to those different coughs, looking for that different thing that happens, or that different effect that happens with this versus other things. So barking cough associated with croup. We also have that inspiratory stridor that we see with that inflammation in this area. And depending on how aggressive these infections are and where they are is going to determine how intense the levels of respiratory distress will be. Epiglottitis is one of the worst. Okay, so we'll talk about each of these conditions. This picture here is just to kind of refresh your mind on where these things are. So our epiglottitis right here, or epiglottis, sorry. Remember, that's the thing that's supposed to close to prevent us from taking water or food into our lungs. So that's supposed to protect us. Thyroid continues to go down, and then we've got our trachea right there. Okay. All right, so if we have acute epiglottitis, so acute comes on all of a sudden, inflammation of that epiglottis, this is a medical emergency because it can get inflamed to the point that it actually closes off the airway. There's no ability to pass air from the nose down into the lungs, okay? You can see our typical cause is that H influenza, clinical manifestations, it's abrupt. We've got some predictive symptoms that we see with this. So it doesn't, we don't go from, just complete closure of the airway. So looking at some of our symptoms, we have absence of spontaneous cough, okay, meaning that kid is not going to be able to clear his airway. Then we start to see some drooling, okay? That progresses into agitation. That agitation is the body understanding that it's not getting enough oxygen. Child's not going to be able to say that. But as we start to progress from that absence of cough, that presence of drooling, and now we've got agitation, this should be a huge red flag into that pediatric nurse's mind. We've got a big, big problem, okay? From that agitation, the next thing is going to be respiratory collapse. So we need to recognize these signs before we get there, okay? Typically, we're going to give these children some steroids to help decrease that inflammation. You can see some of our other treatment here. Start those antibiotics, right? We're related to that bacteria there. Give some antibiotics that are specific to that. And probably those steroids as well, that's going to help us. So 24 hours, a critical period. Once we've been on our antibiotics, once we've been on those steroids, typically we start to turn our corner, okay? For your nursing management, you want to stay calm. The more agitated, the more anxious you are, the more that's going to not only affect the parents or the caregivers, but also the child. The child's going to be able to pick up on that, okay? We want to allow that child to sit in the most comfortable position. Typically, it's going to be upright, or at least with that head elevated, okay? It's going to be the most comfortable position for breathing. The other thing that we want to keep in mind as the healthcare provider is to limit our examination of the throat. And this sounds a little counterintuitive, but the point here is the more we manipulate that epiglottitis, the more likely we are to increase the inflammation there. So it's typically we have that first examination. We understand this is what we're dealing with. And we're not really going to look again for another 24 hours until we feel that inflammation has started to go down. As we start to see decreased needs on our respiratory support, we see decreased drooling and that kind of thing, we start to see some of those symptoms subside, that's going to be what tells us that our situation is getting better, our inflammation is getting better. We want to limit how many times we're actually getting in there and looking, because we're going to make the problem worse. Okay. All right, the next thing we'll talk about is laryngitis. We often associate laryngitis with the difficulty of being able to speak, and that's what happens because it's the inflammation of those vocal cords. All right, so this can happen with our upper respiratory infection, can also be secondary or happen after the upper respiratory infection. Also can see this overuse of using our voice. Okay, so the child's been playing more vocally. We may hear this as well. Secondhand smoke can also cause laryngitis, right? Clinical manifestations, hoarseness, loss of voice, maybe some throat pain, depending on our cause. If we have, if the laryngitis is caused by the upper respiratory infection and we've got inflammation, typically we are going to have some throat pain there. All right. Management is pretty simple here. We need to rest that voice. And humidified air is going to help with that inflammation, right? So it doesn't mean that we have to put oxygen on the child unless it's necessary, but we could just turn on a humidifier. And just to make a point here, I think it comes up later in the lecture, but cool air humidification is much better than warm air humidification because it's easier for those airways to take in, okay? All right, so the next thing we have is that acute LTB. We've got a lot of viral agents that cause this: parainfluenza, RSV, rhinovirus, adenovirus. So because it's typically viral, any medication that we're going to give will only be supportive, okay? So clinical manifestations here, we see that gradual onset of low-grade fever. Typically, we're looking at less than 100, okay? We might have some nighttime awakening with that barky cough. The reason we have it at nighttime is because that child's laying flat and he's not going to exchange air as effectively. And that doesn't become a problem until there's inflammation, okay? May also have some respiratory stridor and some retractions depending on how inflamed those airways are. All right. Therapeutic management is going to be management of that airway. If the child, we put him on a pulse ox and he's showing that he's satting less than 90, we're going to put him on some supplemental oxygen. If he's giving us, showing lots of signs of respiratory distress with the retractions and et cetera, we may have to do something more advanced than just basic nasal cannula, okay? We do supportive care, which means we provide whatever level of care, less invasive care that we need to get his oxygen levels where we need. Breathing treatments can also be really effective, like nebulizers. So they're great at being, if we use albuterol, for example, in that breathing treatment, that's a great bronchodilator. The child's able to breathe that in with the nebulizer, and we expand those airways deep inside the lungs, okay? Steroids we've covered can be really effective in decreasing the inflammation. Humidified air, again, we want that cool air because it is a vasoconstrictor, so it helps prevent that inflammation, helps kind of tame down that inflammation. Continuous monitoring as far as our respiratory, we make sure that we're following that SpO2. We count our respirations frequently to see how effective our treatment is being. All right, why do we have that last point of encourage parent presence? How is that going to help this child?
Make them feel more comfortable?
Absolutely. That's a great point, Amber. It's going to make him feel more comfortable. He's more likely to rest, and then we can get past this, okay? Typically, we see acute LTB in children that are 6 months to 3 years. It also typically follows an upper respiratory infection. The cough that's associated here, that barking cough, is related to that tracheal obstruction, okay? Any questions as far as our croup infections? No.
So the acute epiglottitis, the laryngitis, and the LB are all under part of the croup syndromes, right?
Yes, all three of those are croup. Yeah. So you're gonna hear that barking cough for all three of them. Really looking at those other symptoms or how they progress is going to tell you which level we're at. Okay, so that epiglottitis is the most serious, because if that closes off, if it gets fully inflamed, then we're looking at no ability to pass air through. Okay. All right, next we're going to talk about our lower airway infections. All right, so the first thing that we're going to talk about is RSV. This is also called bronchiolitis. This is a really important condition to understand. Most are caused by RSV, which is why we just call it RSV. There are other types of bronchiolitis, but we are going to focus on that RSV, okay? When we look at RSV, this is the most common reason for hospitalization of children less than 1 year. When we look at risk factors, prematurity is the greatest risk factor when it comes to RSV because we have those underdeveloped lungs. Even when we send those children home, they're still underdeveloped. They're not at 100%. You know, if they're 6 months old when we send them home by time frame, we talked last week about adjusted age. They're 6 months old chronologically, but they're not 6 months old in their development. So even going home, they're still underdeveloped. All right. The other factor that affects our prematurity is that that child also has a decreased immune response. So we see that factor there as well. Okay. So prematurity is the greatest risk factor. The younger that child is in his chronological age and the earlier he was born, the more likely he is to have severe effects of RSV. Okay, so if we have a 24-weeker who is now 6 months old, he is at greatest risk, or he's a greater risk than that child who was born at 22 weeks, who's 5 years old. Okay, so that 5-year-old was born earlier, but he's had an additional 4.5 years to expand his lungs, to build his immune response. So he may have some big effects from that RSV, but that 6-month-old is going to have the biggest effects, more likely to be hospitalized and to potentially die from the RSV because his lungs are still so immature and his immune response is going to be very poor. All right, does everyone understand that? Okay. When we have children that we're sending home during RSV season, there is a medication. It's often reported as a vaccine. It's not a vaccine. It's actually an antibody that we can give to the child. It's called Synagis. You don't have to know the name of that, but it's a medication that we provide for high-risk infants that we're sending home during RSV season. It kind of, the way vaccines work, it exposes them to a small amount of the virus so their body can build the antibodies. So if they were to come in contact with RSV, they may be able to fight an infection. Okay. So it's a really expensive medication. It's not something that we can give to every baby that goes home from the NICU, but our high-risk babies, our babies born really early, are the ones that are going to get it. Okay, so clinical manifestations, it begins with that upper respiratory infection. I'm so sorry to hear that, Daniel. I'm glad that he was able to work past that. So we start with that runny nose, that rhinorrhea, that pharyngitis, coughing, sneezing, might progress to wheezing. We also might have that possible eye or ear drainage, intermittent fever. Okay, so typically it starts out kind of as your average upper respiratory infection. All right, as it progresses, we see that increased coughing and wheezing, tachypnea, retractions, and cyanosis. How fast it progresses and how severe it progresses really depends on the child, right? So how young he is, was he premature, and how is his immune response, okay? So prematurity, biggest factor, but if we have other things that may decrease that child's ability to fight infection, that can be a factor here as well. And if he had another infection, as Danielle's talking, pneumonia can bring down the body's trying to fight that first infection. If he's also exposed to RSV while he's fighting that other infection, more likely to have greater effects of it. Okay. So progression, we have increased coughing and wheezing, tachypnea, retractions, and cyanosis. This is typically in the progression of symptoms is typically when the child is either brought to the doctor's office, hopefully to the ER, somewhere he can get immediate help. Okay. Beyond that, we go to severe tachypnea. So we're over 70 beats per minute in that infant period. The child gets listless, meaning he's really apathetic in his movements. We start to see more apneic spells, poor air exchange, decreased breath sounds. From this point, we're going to go into respiratory collapse. Okay. So our hope that is if we don't see this child in the initial period, which we may not, because this is typically, your upper respiratory infections where you're going to be kind of in that wait and see period. Hopefully we're catching them in the progression of symptoms so we can start facilitating some respiratory support before we get to that critical point. Okay, so you can see our therapeutic management is supportive. We do whatever that child needs us to do. That cool humidified oxygen is going to help with that inflammation and also provide some supplemental O2. We're going to do nasal suction as needed to make sure that we're clearing those pathways. Feeding is not going to be a priority for this child, right? Last week we said with our cardiac babies, the body's going to choose to focus on what the heart needs rather than to be interested at all in feeding. See that same thing here. And the more mucus we have in this area, the less likely that child is going to be interested in feeding at all. Okay. So we may have to start some IV fluids to make sure that child is getting enough nutrition and enough fluids to not get dehydrated. All right. Contact precautions are going to be critical for RSV because this is something that can be passed so easily. For the older child and for the adult, I mean, this just really presents as the common cold. It's really not that big of a deal if we have an immune system that can fight this. But for that young child, that premature child, it can be very, very severe. Okay, so breastfeeding promotes those passing of antibodies, so that can be a great preventative tool, just like with the ear infections, avoidance of passive smoking. And again, that vaccine that you're seeing listed there, not really a vaccine, it's really of an antibody that we can provide, but vaccine's the easiest way to think about it. All right. Any questions about RSV? It's really important that you understand this one. No. All right, are you guys ready for a break? You want to take a quick 5-minute break?
Yes.
All right, we'll come back at 8:31 and keep going.
So you're kind of saying that RSV can lead to this, right?
No, this is RSV.
I mean, what upper respiratory one you said can make its way down if it's not treated and
Any of them. Yeah. It starts as an upper respiratory infection. The pathogen enters in here. And if we don't treat it, which, I mean, if it's viral, we wouldn't necessarily treat it. It can get down into those lungs. The bronchiolitis is that inflammation of the bronchioles. And that is what could lead. RSV is a specific type of bronchiolitis. It's a specific pathogen that can be that bronchiolitis. Because it's the most common type of bronchiolitis, it's typically the one that we focus on.
Thank you.
Does that help? Okay.
Yeah.
Okay.
Just a smart one.
All right, let's jump right back in. The next thing that we're going to talk about is pertussis. We also often call this the whooping cough. This is another one, if you haven't heard this cough before, it's a great thing to go to YouTube and kind of listen to a soundbite of it. It'll be a great comparison from that croup barking cough and that whooping cough, but it really sounds like the child is going whoop when he coughs. All right, so looking at distinctive symptoms, that whoop is going to be, that whooping cough is going to be very specific to pertussis. It's going to be severe to the point that it can cause respiratory distress. Again, the smaller the baby, the more likely we are to see those respiratory effects from that cough, okay? Often comes with a low-grade fever and those upper respiratory infections, as those symptoms as well, that runny nose, that extra drainage, etc. Okay, this is a bacteria, so we're going to give some antibiotics. It's highly, highly contagious. Incident is highest in the spring and winter months. The highest morbidity and mortality is in our infant period because they're not vaccinated from this bacteria yet. Okay, pertussis is part of our DTaP series, and the infants don't get this. They're not fully vaccinated until later. Okay, so infant most likely to have severe effects here. It is highly contagious. This was, along with polio and some of those other issues that we have vaccines for, this is one of those things that we had almost eradicated, meaning that there was no potential for anyone to really get this disease. But we've had a increase, different schools of thought when it comes to vaccinations. Some parents or caregivers have decided not to vaccinate their children. And so we got to a really, really low reportable point with pertussis. And then as that anti-vaxxer movement really took hold, we started to see pockets of this. So every once in a while, we'll have a reportable case of like 5 to 10 cases of whooping cough in a school system. I think there was one in Houston not too long ago. Round Rock had one a couple years ago. Typically, it's caused by parents choosing not to vaccinate their children. Okay, not really going to go on a whole soapbox of that. But if we're looking at how that could affect other children, we could have a couple of kindergartners who are off in school. One kindergartner is unvaccinated. The other 5-year-old picks that up, brings that home to his infant sister, and now we've got a bigger problem. Okay, so it is highly contagious. The best process is to remain isolated, to stay home for at least 5 days. That helps work through that ability for the antibiotics to fight that infection, takes away the ability to transmit that that virus to other people, not virus, that bacteria to other people. So kind of that social thought of helping the rest of the society is to stay home. Okay, we could go into a long conversation here about how the social point of vaccines. We'll avoid that because it's not really going to help you in your exam. But just understand that the infants are going to be most affected by pertussis because they're not vaccinated yet. And then we've got the decreased immune response just from being so young as well. Okay. All right, the next one is foreign body aspiration. When we look at our infants, last week we talked about how they go from just looking at objects to actually being able to crawl. Once the baby starts to get able to move, whether it's through crawling or whatever mechanism, we have to be a lot more mindful of things that are choking hazards. Anything that they can put in their mouth, little buttons, coins, etc. Want to make sure that that's not something that child has an opportunity to get. Those of you that have been around small children know they pick up something, the first thing that they're going to do typically is put it in their mouth. Okay, so by eliminating that risk, you can protect them. We also have to think about it from a food standpoint. When we're cutting things, we want to make sure that we cut them in small enough pieces that should the child just swallow it whole, as children like to do, that it's not something that's going to block their airway. Okay. So in this situation, the child has aspirated either a toy or a food into his trachea. We're going to see that child choking, gagging. We may see some drooling, wheezing. The wheezing is him trying to breathe around that. Okay, any stridor that you hear is the air trying to pass around that. Okay, we're going to confirm this with the x-ray. We'll be able to see that there's a blockage. We may not be able to tell what the object is. Your role here is to watch for this situation to worsen. Okay, the longer that object stays in there, the more irritation it's causing on that trachea. The more that trachea gets irritated, the more inflammation we're going to see. So we can have something that's just a partial obstruction that the child's able to breathe a little bit around it. But as that irritation increases, we may get to full blockage. So your job is to watch that child for worsening signs of respiratory distress. What you would see is that child that was kind of talking or babbling, depending on his age, is no longer talking. That would advance to cyanosis and collapse. Hopefully we can get that object removed before. All right. Typically, if we get down into the trachea, coughing is not going to be enough. If we're sitting at the epiglottitis, typically the child's going to be able to cough that up, right? That's that compensatory mechanism with the epiglottitis. Excuse me, the epiglottis gets inflamed, gets irritated, and it kind of just pushes things back up, right? We have that cough reflex. We get that object out of the way. If it makes its way down into the trachea, the coughing reflex is not going to help us. So we're going to need to do a bronchoscopy to remove that. Okay, so we have the cough, we have potential Heimlich maneuver. If it gets down into the trachea, we're going to need that bronch to remove it. Okay. So as far as your education, both for yourself and for the parents or caregivers, never do the blind sweeps. We know that that's a big risk of pushing the item further down. If the child's not able to cough it up on his own, the Heimlich maneuver didn't work, now we need some emergency care. Okay. All right, now we're going to talk about asthma. This is a really big condition to talk about. Lots of things that can go into it. What happens with asthma is we've got inflammation of the bronchioles. Okay, you can see we've got different classifications of severity there. Step one is mild intermittent asthma. Typically, this does not have effects more than two times per week. All right. If we have step one, we're going to give a short-acting beta agonist for symptom control. All right. Typically, we're just going to give that less than 2 days a week, so that the medication has enough time to sit, expand those bronchioles. The more severe that we get in our classification, the more intense our therapy is going to get, or our treatment, right? So step two, we have mild persistent asthma. Now our symptoms are greater than 2 times per week. Treatment here is going to be the same as it was for step one. We've got that short-acting beta agonist for symptom control. Then we moved on to step three. Now we've got moderate persistent asthma. At this point, the child is experiencing asthma symptoms daily. Okay. At this point, we'll move that short-acting beta agonist. We're going to move to daily control. Okay. And then step four, now we've got severe persistent. In addition to that short-acting beta agonist for symptom control several times a day, we're probably going to have an emergency situation as well. Okay, for whenever those big severe events happen. All right, so with our causes here, we have exposure to allergens. previous RSV, we just covered RSV. We said that that is a bronchiolitis. So we've got inflammation of the bronchioles. Children that had severe bronchiolitis, whether it was related to RSV or another cause, are at risk for developing asthma from damage to those bronchioles. Children born premature are also at risk for developing asthma at some point in childhood for that same rationale, okay? Damage to those bronchioles can affect them later in life through the point of asthma, okay? Clinical manifestations, we know wheezing is the first thing that we think of when it comes to asthma. That's where that albuterol is so helpful as that bronchodilator. We may see breathlessness, chest tightness, cough is especially common at night with repeated episodes. So as that asthma progresses from that step 1 into that step 4, we may see children start to get barrel chested. We may also see the elevated shoulders, use of accessory muscles. There's also kind of some facial changes that happen in chronic asthma. We may see some flattened cheekbones, some circles under the eyes, a narrow nose, prominent upper teeth. That's all related to the mouth breathing that happens as that compensatory mechanism of trying to take in more oxygen to expand what's circulating in the body. Okay, we diagnose this based on the clinical manifestations, based on the history that the parents or caregivers provide to us. We can also do some pulmonary function tests to look at how well that child is able to expand. And then we've got our therapeutic management. If we've got allergy-induced asthma, the first thing that we want to do is try to figure out what that agent is, right? We can't control it until we know what it is. This can be a seasonal allergy thing, sometimes going on something like a daily Claritin, especially during that, whenever that season may be, can be helpful. If it's something that is related to maybe, you know, in the washing detergent or something like that, then we go to full avoid exposure, okay? The drug therapy we've talked about can give the corticosteroids that help with the inflammation. The bronchodilators help expand. The amount or the way that we have to give those medications all goes into how severe that asthma is, okay? So nursing management includes teaching the prevention of exacerbations. So really understanding what's causing it. Is it allergy induced? Is it sports or exercise induced? Relieving those bronchospasms through the medication. Exercise can be helpful as well. We just want to make sure that it is not something that's going to aggravate the type of asthma that we have. As far as the asthma teaching plan, there's several key people that we want to have involved here. If it's severe asthma, the child may be seeing a specialist, maybe seeing a pulmonologist. Most asthma can be treated with the primary care physician, with that pediatrician, okay? So we've got the pediatrician on board, we've got the parent or caregiver on board. The other people that we have to loop in is going to be if that child's in daycare or if that child goes to school, we want to share with those caregivers as well. What happens, what the child looks like when he's going into one of his asthma episodes, what to do about it, how to know if this is just a typical episode that the albuterol is going to help with, or is this something more severe where that child is going to need more help? We need to call EMS, call parents, etc. Okay, so we need to make sure everybody knows what the plan is for that child. That is the best way to prevent an asthma event turning into something more severe that could lead to potential respiratory collapse. Okay, so looking at those early signs before it becomes big. All right, so the short-acting beta agonist, I mentioned earlier, albuterol is the #1 choice here. We also can provide a rescue inhaler for symptomatic treatment. Typically, we've got our daily treatment or our less than twice a week treatment if we're mild, that daily treatment, and then we've got a rescue inhaler as well. Okay, for long-term preventative, those corticosteroids are helpful for preventing or decreasing inflammation. Mast cell stabilizers are also anti-inflammatory drugs as well. Long-acting beta agonists, we've got the bronchodilator. Theophylline can be another medication that we give. There's lots of medications listed on here. What I want you and need you guys to understand is albuterol is our first line of defense when it comes to asthma. Okay, that is our number one course of treatment that we're going to give as that short-acting beta agonist, does the best at opening up those airways. As the condition gets more severe, that's when we have to start adding in these other treatments. All right, everyone understand that? All right. All right, next thing we're going to talk about is cystic fibrosis. All right, so cystic fibrosis is included in the respiratory section, but there are GI components, there's pancreas components as well. If you look at, oh dang, I didn't open up my notebook. So it's page 1162 in the new textbook, box 48. Let me find it. It's 1152 in the 7th edition, box 4010. That gives you a great concept map of cystic fibrosis. And if you look at box 4016 or 4017 in the old textbook on page 1154, that's going to break down all the different symptoms, whether we're looking at respiratory, GI, or pancreatic. Okay, got a good slide coming up soon too that's going to help you with that. All right. So this is a genetic disorder. All right, means that both parents have to have this. Both parents typically are carriers of cystic fibrosis. Those carriers come together, they produce a child that has cystic fibrosis. There's a 1 in 4 chance if both parents are carriers of that child getting the condition. What happens with this is we've got increased viscosity of mucus gland secretion. So it affects all 3 of those systems. The first thing that we typically see if it's not detected. So let's go back just a little bit. We can detect this when the woman is pregnant. This is one of the things that we can look for as a genetic marker. The other thing the other way that we would detect this is on that newborn screen. And I'm certain you guys talked about newborn screen when you talked about the newborn. So in Texas, last I checked, there are 57 genetic disorders that we screen for in Texas. All right. Some states do more. 57 is a good number to cover the biggest things that are possible. Cystic fibrosis is one of them. So if we didn't test in the pregnancy, then we're definitely going to test here, okay? If we test in pregnancy, it's because we know that there's a risk factor here, all right? If we don't have a familial history, we don't know that there's a risk factor, we're gonna catch it on the newborn screen. But that newborn screen, we do typically somewhere day 2 to 3 of life. We're gonna repeat it again at 2 weeks. We're not gonna get that information right away. The first red flag symptom that we're going to see in our newborn that we may have cystic fibrosis is a meconium ileus. All right. What a meconium ileus is, just to make sure that we all understand, meconium, remember, is that first stool that baby is going to pass. Usually, depending on how efficiently that baby is eating, we're going to transition from meconium to our regular stool within 72 hours. But that meconium ileus means that baby is not going to poop within the first 24 hours. Remember, that is a big red flag. The baby should poop if he's eating within that first 24 hours. If he does not, we know that there's a problem. All right. So that meconium ileus is the first sign that we may have cystic fibrosis. All right. It's not definitive. It's not meconium ileus equals cystic fibrosis. It's just that first big red flag symptom. Okay. So we would do further testing. We're not going to wait for that newborn screen to come back if we've got that meconium ileus, because we can't feed our baby if he's got that ileus, because we could get to a point where we perforate the intestines. Obviously, big issue there. Okay. So meconium ileus leads us to do further testing. We're going to do some scanning. when we get to that, we see that meconium ileus on our scans, that's going to say we need to test for cystic fibrosis. Okay. There are times where that meconium ileus is not so great, where it prevents stool. Okay. We can also see situations where we don't have that meconium ileus, even though we have cystic fibrosis, which is why we still have to include it on our newborn screen. Okay, so can see that meconium ileus as our big first red flag, may lead us to earlier testing. We may not have that, which is why we have the newborn screen, which is going to help us. Okay. All right, so looking at our respiratory manifestations, we have stagnation of our mucus. We've already covered talking about our respiratory infections, the stagnation or the lack of movement in that mucus increases the likelihood of pathogens coming in and causing infections. All right. The other big factor here is that those secretions are very, very thick, which means that as our child is trying to cough them up, they get stuck. Okay. Those secretions can get down into our lungs, and now it's going to cause some obstruction. It's going to affect the way that our child is able to oxygenate. All right. It's called obstruction bronchial. All right. Bronchiolitis. So we've got that obstruction, we've got that inflammation. All of that is what helps or what progresses our respiratory distress, could lead to respiratory failure. All right. You can see some of our big complications here related to the respiratory effects: compression of pulmonary blood vessels, progressive lung dysfunction, could lead to pulmonary hypertension, cor pulmonale, respiratory failure, and death if we don't treat it. All right. We're going to talk about the treatment all together in just a second. I want to get through all of our symptoms first. All right. So that's respiratory. Next, we have GI. And we're going to loop or link in our pancreatic effects here as well. Okay. So big factor is pancreatic enzyme deficiency. That's something that you really need to understand here, because one of the treatment things that we have to do is replacement of that. Without that pancreatic enzyme, we're unable to process things effectively. It affects our insulin as well. Okay. Can lead to failure to thrive. So let's say, maybe we did the newborn screen, but we didn't have great follow-up care with the parent or caregiver in that first year. The pediatrician never was able to share that information. If we don't start cystic fibrosis treatment early on, and we've got early effects of it, it can lead to failure to thrive. Failure to thrive we covered last week, which means that our child is unable to process things effectively. We start to see kind of that wasting. He's either uninterested in food or he's unable to utilize that food effectively. Okay. That increased weight loss despite increased appetite. These children, increased weight loss despite increased appetite. Make sure I say that correctly. These children can take on a lot of food, high calories, high fat, etc. But because of that lack of pancreatic enzyme, there's malabsorption, and it doesn't really matter how much they take in. If we're not replacing those pancreatic enzymes, we're going to continue to see that malabsorption. That malabsorption is manifested in sederia. Remember, that's our fatty stool, because we're not processing fats effectively. All right. We're going to get eventual diabetes from that pancreas, from the pancreatic fibrosis. Even with effective replacement of that pancreatic enzyme, this is something that can happen. All right. We also have eventual cirrhosis from that fecal biliary obstruction. Typically, there's some surgical interventions that we can do if we get to that point. Now, putting them all together, listing all the manifestations out there for you. We've got the wheezing respiration, the dry, non-productive cough. We've got generalized obstructive emphysema, patchy atelectasis, meaning that we're going to have poor gas exchange. Cyanosis comes from long-term deoxygenation, clubbing of the fingers, again, chronic deoxygenation. Remember, not something we're born with, something that develops. Repeated bronchitis and pneumonia. Because of that stagnant mucus, pathogens get trapped in it. more likely to cause infection. Wasting of tissues, delayed puberty in females because they're not hitting those milestones and we're not releasing the correct hormones from our pancreas as well. Dehydration, sterility in males. Parents report children taste salty. I always find that this point always makes me laugh because who is going around licking their children? But when we talk about the diagnosis or the way that we diagnose this in just a second, that'll make more sense. From electrolyte standpoint, we see that hyponatremia, hypochloremia, hypoalbuminemia, the meconium ileus we already covered, distal intestinal obstruction syndrome, excretion of undigested food and stool. That's that steatorrhea that we talked about. It's very, very stinky. It floats, kind of has a gray appearance to it. And then because they work so hard to pass the stool, it may actually cause a prolapse of the rectum because they're working so hard to try to poop. Okay, so how are we going to diagnose it? So we start with that newborn screen. The newborn screen, remember, is not definitive. It just says this child has a genetic marker and we need to go deeper in our testing. The deeper testing that we do is the sweat chloride test. Okay, so the sodium and chloride will be 2 to 5 times greater in children with cystic fibrosis than in the controls. This is why parents report the children tasting salty. Again, I don't know which parents are going around licking their children, but this is our connection here. Okay, the chest x-ray is going to help us look at the functions, is going to tell us if it's advanced cystic fibrosis. By the time that we have diagnosed it, we're going to start to see some physiologic changes. Okay, pulmonary function test is going to help tell us how well that child is able to exchange gas, how well he's able to function. Stool fat and or enzyme analysis is going to tell us where we're at with the malabsorption, where we're at with our pancreatic enzymes. And then the barium enema can both be exploratory to see what's going on, but may also be effective in trying to clear out anything that may be in those intestines. Okay, so it can be exploratory or diagnostic and a treatment as well. All right, so what are we going to do for these children? There is something that is called CPT. This is chest physiotherapy. What CPT does is basically you're going to beat on the back of the chest. The bigger the child, the more hard, or the harder you're going to have to beat to try to break up that mucus. In the NICU, when we are doing CPT on our babies that have thick mucus, we have this tiny little vibrating thing that we just put on their different points on their back to help break up that mucus. That's really effective for a baby who's, a couple pounds, not going to be effective for a big child. Okay. And for bigger children, we really have to beat really hard because the fact is we're trying to break up that mucus. Okay. That needs to be done at a minimum once a day, typically more frequent. It could be, once a day. Typically we may have, if we've got a period of increased mucus, we may do it more often. Okay. Bronchodilator medication is another big thing. We want to keep those airways open. Meticulous, or that forced expiration is the child really just having those harsh coughs that's going to move up that mucus and hopefully expel that. Okay. We have to prevent or be very aggressive when we come in contact with pulmonary infections, because that can cause so much damage to our already damaged lungs. So the early signs, this is the child that has the runny nose, that has a little cough that's different than his usual cough. They need to go in and they need to see, is this viral? Is this bacterial? If it's bacterial, we need to start antibiotics and be very aggressive with our treatment right now. Okay. Hand hygiene, meticulous hand washing for all of the time, not just when we suspect an infection, is going to help prevent those respiratory infections as well. Aerolized antibiotics are going to help get those antibiotics deep down into the lungs so that we're doing the best to prevent that infection. Steroid NSAIDs can help as well with that anti-inflammatory mechanism. When we talk about our diet needs to be high calorie, high fat. Let me repeat, high calorie, high fat. Because of the malabsorption that is associated with this, we're really just throwing as many calories, as much fat as we can at this child because we need them to just hold on to something. Okay, we're probably still going to see decreased growth as far as following where he should be based on chronological age. He's probably going to be smaller. Okay, but the more calories, the more fat that we can give him, and I mean, we don't want to feed him garbage. He's not going to eat a dozen donuts every day. We want it to be nutritious food. We just want to think about that high calorie, high fat, healthy fats that are going to be helpful. We also need to have pancreatic enzyme replacement therapy. And this is something that it comes in pill form, but for our younger children, we can just sprinkle it on the food that they're already eating to help encourage them to take, okay? Because it is a capsule, it can be difficult for young children to swallow. So literally just sprinkling it on whatever you're feeding them will be helpful. Long term, the child may need a transplantation. Okay. When we talk about the prognosis of cystic fibrosis, the survival rate used to be very, very low. If a child actually got into his adolescent period, in the 90s, that was a huge accomplishment of the family, of all of the healthcare providers. But life expectancy continues to increase in children because we do have better ways, more effective ways of treating this. The likelihood of needing that lung transplant still exists though, okay? So survival rate now is about 55% at 3 years post-transplant, which again is a huge increase of where it's been because we are so much better at our surgical procedures, at our management of post-transplantation. So this used to be a death sentence. So it's another thing that's getting better based on the ways that we have to treat it. Okay, so family support, we need to remember that this is a lifelong condition. Okay, this is something that this family is going to have to deal with, this child is going to have to deal with for as long as he survives. The better we can be at preventing those infections and providing the best treatment, getting the family to really get on board with the treatment plan, the longer and higher quality of life that child is going to have. Okay, so we follow nutrition very carefully, we prevent that infection, and from a health provider standpoint, we continue to engage in ways to improve the care that we're providing. All right. So that is the end of the respiratory lecture. We only have a few more minutes, so there's not really enough time to get in to the next section. My hope is, let me see how long these sections are. So GI, about 30. My hope is to get through GI and GU, both sections tomorrow. I don't want to rush. I want you guys to get the content effectively. If we don't make it through GU tomorrow, then we'll start with GU on Monday, and whatever time we have left, we will use that to review. Okay, try to give you the best review of content that I can, give you an opportunity to ask your questions as you're studying for the test next Tuesday. We are going to use one of the new classrooms to test. I know you guys have been basically sitting on top of each other in 107. So I am going to, tomorrow when I get back to campus, I'm going to go look at the rooms downstairs, and they don't have Wi-Fi set up. That's not going to matter to us because we're doing a paper test. But we're going to use one of those new classrooms. And once I figure out which one we're going to use, I'll post an announcement so you guys know where to show up next Tuesday. All right.
That room is horrible for
I
it.
know.
Like,
We have been just waiting for those new rooms to open up. And I, as soon as I took over this class, that's the first thing I went to Dr. Jessup with. And so she's fine with it. Everyone's fine with it. I just need to see which room we're going to use. Rebecca downstairs said both are available. I just need to pick one. I don't even know if they have numbers yet, but we'll figure it out, and I'll post that. You guys have any questions before we leave for today?
Yes, I had a question. It cut out on my end. When you
Okay.
said for the cystic fibrosis, what was the diet?
High fat, high calorie.
Thank you.
You're welcome. Anybody else? No? All right, I'll get this recording posted as soon as I can, and I will see you guys all tomorrow. Okay? Have a great day.
Thank you, you too.
Bye.
Yeah.
Bye.